here is your advancer,
Okay.
and I will try to keep you on track.
Thank you very much, Laura. Appreciate it. It's a pleasure to be here and get to talk to you a bit about rheumatology from the arthritis, the rheumatologist perspective. I'll try my best to answer your questions at the end, but first, I have no disclosures. And the talk today, we're going to focus on really three of the main common types of arthritis that a rheumatologist will see, which is in a sea of many different types of arthritises. We'll talk about their similarities and differences, identify important signs and symptoms that we use as rheumatologists to differentiate them, and then we'll evaluate some of the treatments as well. So before we get into a talk about what are all of the arthritises, what is arthritis? And the kind of lame answer is it's a collection of more than 100 diseases that cause joint pain. So when you talk about arthritis, you're necessarily talking about pain, but just as the prior speaker was discussing, it's what's causing that pain, and that's what the rheumatologist is trying to figure out, and then that's what ends up determining the treatments that we give. So then what's a rheumatologist? Cardiologist, oh, cardio, that means heart. Pulmonologist, pulm, that means lung. What's rheum? It means river in Greek. It's not really, doesn't mean anything really. But we're a doctor who we treat connective tissue diseases, and connective tissue covers our entire body, including our joints, but not just our joints. So connective tissue diseases are often very rare, which brought me into the field. I like rare diseases. We're kind of a Dr. House doctors who figure out the medical mysteries or try to. But connective tissue diseases affect multiple parts of the body, not just the joints. Many are autoimmune, so we often use immunosuppressing medications to treat them. But you can see on the right side of the slide just a small sample of the diseases that we treat, highlighting the three that we'll focus on today, but we treat many different types of connective tissue diseases. So arthritis can have many different forms. So we'll first discuss osteoarthritis, which is not autoimmune and it's not inflammatory, which is misleading because it kind of is, but it really isn't. We'll talk about rheumatoid arthritis, which is the exact opposite. It's autoimmune and it's inflammatory. And then we'll talk about gout, which is not autoimmune, but it's inflammatory. And we'll understand what that means in a moment. So like I mentioned earlier, when you're talking about arthritis, you're talking about joint pain. And the first thing a rheumatologist is going to need to do to try and figure out what's going on is to determine if the pain that you're experiencing is inflammatory joint pain or non-inflammatory joint pain. And we're going to ask you a series of questions about the characteristics of that pain and also look at the entire body to see are there other issues in the body that might be connected to that joint pain as well. So characteristics of inflammatory joint pain, for instance, is hours of morning stiffness, warmth, redness, swelling of that joint. It's actually hot to touch. Are you having other issues with your lungs or your muscles that might be, or your eyes that might be connected to this? Non-inflammatory joint pain tends to get better when you rest. It gets worse when you use that joint. You may have certain characteristics on X-ray and other investigations that make it appear non-inflammatory, but most importantly, it's not going to get better giving people anti-inflammatory medications at the end of the day. So we'll start talking about osteoarthritis. I don't need to probably spend too much time based off of the last talk going into great detail about OA, but what is osteoarthritis? So it's the most common arthritis in the world. So including babies to the eldest people in the world, about 8% of people globally have osteoarthritis, but symptoms do tend to start after the age of 40 to 50. And it's the leading cause of disability in the elderly. And we commonly refer to OA as kind of the wear and tear arthritis. And it's a slowly progressive degenerative disease of cartilage in the joints, and most commonly affecting hands, the spine, hips, knees, and feet, basically joints that bear weight or perform repetitive motion. So for instance, boxers are going to get hand arthritis, or when there were lots of seamstresses commonly got arthritis in the hand that held the needle. Ballet dancers will get osteoarthritis in their ankles. And you can see here a hand affected by osteoarthritis when you can see these nodules. I don't know if I have a pointer or not. So you can see at the tips of her fingers these sort of bony nodules, which is a natural reaction in osteoarthritis. So what does it feel like? So as I was discussing, it's a non-inflammatory arthritis, so it's going to be painful with activity, that's going to improve with rest. The joint may have a limited range due to changes in the cartilage that are happening inside. The joint can be tender, but it's going to have these deformities like you saw on the last slide, these nodules, these changes in the joint, which are going to cause the normal alignment of that joint to be abnormal. And doctors call that subluxation, which is, you don't need to remember that. And some of these deformities, for instance, if it's in your knee, can cause buckling when you're walking, or feeling of instability when you're walking, or decreased grip strength, feeling like you're having trouble using your hands for things. And you can get this phenomena called gelling, which is this kind of the stiffness. If you're immobile for a while, it almost feels like there's like lead inside your joint, and then you kind of need to walk around to loosen it up a bit. And actually, it's and I put lightning bolts there just to show the most common sites again that are affected: spine, hips, knees, ankles, and hands. So repetitive motion or weight-bearing joints. So despite it being the most common arthritis in the world, affecting many people in this room, me included, and many people in the world, we don't know a whole lot about really why it happens. We know what happens. It's the cartilage breaks down and gets sickly, and there's local inflammation which damages cartilage. And over time, the cartilage will wear, it gets more micro trauma and degrades, and then eventually you get bone-on-bone osteoarthritis, which looks like this on an x-ray. So if you look at the left side of the screen, that's a normal joint, and the x-rays can penetrate through cartilage. It's like it's not there, so you see that gap, of that nice black gap between the two bones there, and that's cartilage. Over time, that cartilage wears away, and you can see this knee on the right side has lost most of its cartilage, so that's what we say bone on bone, because it looks like it's bone on bone. But then the bone reacts to that loss of cartilage, so you can see it's a lot thicker or whiter in that area. And then you can see these wisps around the knee. And those are kind of spurs that form as a reaction to that loss of cartilage. And this is all evidence of osteoarthritis, but it's that bone on bone and that irritation, that local irritation, which causes the pain. So when we're thinking about treating osteoarthritis, as our last speaker went into gave a great talk about, we really push non-pharmacological treatments. Why? They're safer, they're often cheaper. They can actually, it's the only thing that has been shown to potentially slow the progression of osteoarthritis, which does not have a cure. But they do have a gradual onset of benefits. But many of the treatments also offer benefits outside of reducing your joint pain and improving your mobility and function. They also have cardiovascular and mental benefits as well, higher quality of life. Pharmacological treatments have side effects. There are contraindications for certain patients, for instance, kidney disease. They don't prevent the disease, but they can offer sometimes more rapid relief of symptoms. And then there's always surgery if you need it at the end of the line. So when I think about osteoarthritis or an osteoarthritic joint, I think about a hinge. We can do physical therapy to improve the biomechanics of that hinge, so we can make it so the hinge works a bit better. We can make sure that it's aligned properly with the door. We can also make the door lighter so that the hinge has to work less hard or gets less stress when you're moving it. We can lubricate the hinge, and we can put medicine inside the hinge to help it squeak a bit less. Or we can use pain medication just so we don't have to hear the hinge squeak. So without going into too much detail based on our last talk, we have non-pharm treatments. So weight loss, when we break that down into more concrete steps, what that means is if you lose, for instance, 1 pound, that equals a 4-pound reduction in load per step on the knee. Losing 5% of your weight results in 25% improved function of that affected joint. Aerobic exercise is probably one of the most beneficial things you can do, not just for your joints, but for your whole body, including your heart. When we talk about that, we're really saying 30 minutes of light exercise 5 times a week, or 150 minutes a week. It's been shown that, for instance, physical therapy, guided physical therapy, results in a 55% improvement in knee pain. And what exercise is there? Any exercise that you're going to stick to. You're going to enjoy doing. Tai Chi has been shown to be just as beneficial as aerobic exercise, as swimming or yoga. And then using specific physical therapy techniques with a physical therapist to help strengthen and help align your joint, helps reduce pain as well. So what I like to tell patients is when you sprain a joint, you usually put an ACE bandage around it. And why does that help reduce pain and help you heal better? Because you're supporting that joint. And what physical therapy and exercise is doing is you're basically putting a natural ACE bandage around that joint. It's doing the same thing. You're using that that soft tissue, that increased tone of your muscles, that better biomechanical alignment that you get from exercise and physical therapy to support that joint and thereby reduce pain. But if that fails, or usually in combination, we use pain medication, which is really silencing that squeaky joint. It's not helping what's happening under the hood, but it is making you feel better. So Tylenol is a great drug to use because it's very safe to use over long periods, but it's not particularly effective. We then usually step up to topical nonsteroidal anti-inflammatories, so like basically topical Motrin, brand name Voltaren gel, Aspercreme is an over-the-counter alternative, and you can use those 4 times a day very safely to reduce pain. And then there's oral nonsteroidal anti-inflammatories such as your ibuprofens and Proxens or Celebrex or Meloxicam, which we prescribe. And then there's supplements, and we get asked about supplements a lot in rheumatology. And it's controversial because the science behind them is not particularly strong, but there are certainly patients who benefit from them. So the next question is, as we took an oath to do no harm, are they dangerous? And that's why I wanted to include these on the slide. They're not particularly dangerous, these 2 supplements, but the thing that they may not do is help you very much, or they might hurt your wallet if you're spending a lot of money on them, which I don't recommend doing. But chondroitin and glucosamine are a common arthritis supplement to take. If you're going to try it, which it's not, it's very, very safe to try it for 2 months and see if it helps you. Take them all in a big single dose because they're not absorbed very well in the GI tract. You want to absorb the medication, or the supplement rather. Curcumin is an extract from turmeric, and there have been studies not performed in America, in North America, but that suggest that they're equivalent to taking a nonsteroidal anti-inflammatory, but don't have the side effects or the contraindications, for instance, in patients with kidney disease. So they can be a very good option to try, but unfortunately, curcumin is really the active ingredient, and to get purified curcumin supplements are a bit pricey, and taking a turmeric supplement is about 3% curcumin instead of a 95% curcumin supplement. Those are much cheaper, but probably less effective. So it comes to a money question, but it is, I think, worth trying. Then there are interventional treatments, which the orthopedists and other doctors will perform more, but we have certainly, as rheumatologists, do joint injections, and we inject steroids, or do viscosupplementation, which is hyaluronic acid injections, basically a lubrication for the joint. And these both have advantages and disadvantages. But at the end of the day, do they improve your pain or not? And for some patients they do, and some patients they do not. But it's usually a temporizing measure until, to help prevent surgery or to delay surgery if that's needed. There are genicular nerve blocks, so you can get nerve blocks to decrease the pain in the joint, and that's kind of an exception to surgery. And then at the end of the day, if none of this is working, you can get a joint replacement with an orthopedist. So what doctors treat osteoarthritis? A lot. You've got a lot of options. All of our approaches are a little bit different, and it also depends on what joint is affecting you. But primary care doctors are usually the first stop. Rheumatologists may manage more difficult joints over a longer period of time with injections. But there's a new kind of budding area in medicine of physical medicine and rehabilitation doctors who are a fantastic resource as well. And they treat a lot of non-inflammatory joint issues, including osteoarthritis. Orthopedic surgeons, of course, podiatrists if your feet are affected, and then if it's primarily pain and you've unfortunately exhausted all of your medical options, you may need to just have your pain of that joint be focused on with a pain management doctor in certain situations. So let's switch gears and chat about rheumatoid arthritis, which is basically the exact opposite of osteoarthritis. It's the most common autoimmune arthritis in the world, and it affects about 0.5% to 1% of individuals in the U.S. and Europe. And it's a chronic, systemic, inflammatory autoimmune disorder. I'm going to break that down and tell you what that means. But it often starts in the small joints of the hand, and it's essentially inflammation of the joint lining, which causes joint pain and damage. And you can see in this individual on the 2 fingers closer to the bottom of the screen, you can see the middle joints of those fingers are quite inflamed and enlarged and swollen compared to the other fingers of the hand. And that's very classic appearance for rheumatoid arthritis. So what does rheumatoid arthritis feel like? So it's the exact opposite pretty much of osteoarthritis. You're going to have pain at rest, which is going to get better when you're moving around. You're going to have redness, warmth, heat in the joint with stiffness in the morning lasting more than an hour instead of maybe under 30 minutes in osteoarthritis. Also, osteoarthritis tends to affect maybe one joint. It could be on both sides of the body, but it tends to be less symmetrical. So if you were to put a mirror between your legs up through your skull, rheumatoid arthritis is almost like a mirror image as in terms of the joints that it affects. So if it affects your pinky on your left hand, it'll affect your pinky on your right hand. If it affects your right elbow, it'll be your left elbow. That's one of the things that we look at in rheumatology is what's the pattern of the joints? Is it mostly the small joints, and is it going to be both sides of the body? And then does it have these characteristics of inflammation as well? Another thing to note, which you can see in the figure here, is that the spine is not red at all. And while many people have back pain, rheumatoid arthritis, we don't know why, doesn't really affect the axial skeleton or the spine. So it's really a small joint disease is how we think about it. So what's happening is rheumatoid arthritis is basically your immune system mistaking the lining of your joint, your joint capsule, for something foreign, and it's attacking your joint capsule, which then releases a lot of really nasty enzymes into your fluid, which breaks down cartilage and breaks down bone, and you get erosions and you get cartilage damage, which cause increased pain. So you have pain from the inflamed joint lining and then pain also from the damage that's occurring in the joint. What this looks like under X-ray, so you can see this individual has rheumatoid arthritis, and this X-ray was done in 1955. You can see actually just a year later, you can see that erosion in that red circle in that same joint. And the inflammation from that lining of the joint from that finger has actually damaged that bone and caused permanent joint damage. And I'll show you what that looks like in real life in a few slides with chronic untreated rheumatoid arthritis. But like I mentioned earlier, that rheumatoid arthritis is not just a joint disease. Autoimmune diseases are not just joint diseases. It's a common feature of rheumatoid arthritis, but it affects other parts of the body as well because the immune system doesn't just focus on joints all the time. So for instance, you can have nodules that develop in your skin called rheumatoid nodules. You can have scarring of your lungs. So the lungs, the kind of honeycombed area, should look nice and black and clean, but instead it looks kind of honeycombed and scarred, and that's from rheumatoid arthritis. You can have inflammation of the lining of your lungs, which we call pleuritis. You have 2 times higher risk of heart attack, coronary artery disease. You can have inflammation of the lining of your heart. It can affect eyes, including the feared melting eye disease, or PUK, which causes inflammation and eventually holes to kind of occur in parts of the eye and leading to blindness. And late-stage untreated rheumatoid arthritis causes permanent joint damage, severe disability. So this is an individual, you can see the fingers pointing not straight forward, but kind of to the side, and there are kind of contractures in the fingers. So you can go from having pain and difficulty performing basic tasks to being unable to use your hands if you go untreated. So what are the treatments? Well, in osteoarthritis, we really recommend doing as much as possible as you can with the non-pharmacological techniques, and these are very important in rheumatoid arthritis in terms of reducing pain and enhancing your quality of life, but you're not treating the underlying disease by focusing on non-pharmacological treatments. You're really going to need medicine to treat this. And we do have many options, and it's also necessary to make your life expectancy approach that of someone without the disease. Whereas untreated rheumatoid arthritis, say in the 50s when that X-ray was taken, your life expectancy would probably be about 40 to 50. So we've come a long way from that. And then in severely damaged joints, there's also orthopedic surgery. So I used a hinge to represent OA. When I think about rheumatoid arthritis, I think about a bacterial infection because it's your immune system that is fighting the bacteria and causing inflammation and causing that sickly feeling when you're fighting an infection. Except in rheumatoid arthritis, you're replacing antibiotics with immunosuppressing medications, and instead of bacteria that you're fighting, it's yourself that you're fighting. So we're trying to fight our immune system, which is causing this inflammation, instead of your immune system, which is fighting bacteria. But it's kind of the same concept. It's like treating a chronic infection that won't go away. So we use immunosuppressants. You're probably all familiar with steroids or heard of them, prednisone being a very common steroid that we use. And then long-term immunosuppressives. Basically 50% of rheumatology is starting steroids, and then the other 50% is getting people off of steroids. Because the P, what I tell my patients, the P in prednisone stands for poison. And over time, prednisone is very, very harmful to the body. So, but on the short term, it's very safe and effective to use prednisone, but we don't want you taking it for years and years. So we switch patients from steroids to non-steroid medications. We call those DMARDs, disease-modifying anti-rheumatic drugs. And the most common drug that we use to treat rheumatoid arthritis is called methotrexate, but we also use biologics. You've probably seen their commercials on TV, Humira, Enbrel, and such, which are also very effective. When we use biologics, when methotrexate is not effective. But what all of these drugs are doing is they're turning down the volume on your immune system to decrease that inflammation, protect the joints, protect the lungs, protect the heart. And who treats rheumatoid arthritis? Just us, rheumatologists. So the last disease I'll talk about is gout, which is then different from the first two. So what is gout? Well, it's the most common inflammatory arthritis in the world. I didn't say autoimmune, but I said inflammatory. And it affects 3% of people in the world, two-thirds men, one-third women. And that's characterized more by a sudden, severe arthritic attack, often in the big toe, forefoot, or ankle. But in between these horrible arthritic attacks are periods of complete resolution, no pain, no issues. And what's causing the inflammation here, it's not an inflammation of the joint lining or degradation of cartilage, but it's a reaction to crystals in our joint fluid called uric acid crystals. So a gout attack, you're going to know you had it because it's going to feel like someone just slammed a hammer into that joint. It's usually a single joint that's affected, at least during your first flare, usually in your big toe. And it's incredibly inflamed, very hot, very swollen, very painful, very sudden. And it can be so inflamed that you can get something that we call sheet sign, where it's so tender that just the sheet on your bed touching that joint can be incredibly painful. So it's not like the others where they're chronic, they're progressive. You can get flares of pain in multiple joints. Gout is really one joint like a thunderbolt, just striking it. Very, very rapid and very painful. And then over time, you can develop what are called tophi, which are deposits of uric acid in the body. And I'll show you a picture of what that is in a slide or two. But you can see on the left side of this slide, the inflamed big toe on this patient's right foot. And if I were to look under the microscope on the joint fluid, what's in that joint fluid, you see these kind of needle-shaped crystals, and those are uric acid crystals. And we actually do try to test fluid if we have it available or we can extract it to look for those crystals under the microscope to help make that diagnosis. So you can see the fingers on the left side of the slide have these like nodules on them, and then so that's that uric acid. Those crystals are depositing into these lumps and bumps on the body, and someone with gout who doesn't get treatment, these can develop and become inflammatory themselves and painful or just unpleasant to have. We can use special imaging as well, called dual energy CT, to also look for uric acid, and you can see that the green kind of splotches that you see on this foot over here, that's actually what uric acid looks like in a dual energy CT study. And we use this sometimes when it's not clear if it's gout or if it's another arthritis to identify uric acid. Well, you can see that it's depositing around the joints, but also not just around the joints, but also behind the heel where there, where there's a bursa or another part of connective tissue. So the uric acid can go really anywhere, not just inside of a joint. So how do we treat gout? Well, we need to use medications. Surgery is very rare, and that might be to remove a tophus, but usually we can dissolve them with medication. We can get rid of them just with medicine. But also, a nice thing about treating gout is it also may reduce your risk for heart attack and stroke, which is always a nice plus. So when I think about gout, I think about how do I get salt out of a beaker that's full of salt. And so we're not treating a bacterial infection, and we're not treating a rusty hinge. I'm trying to get salt out that's super saturated. So and when you fill up water with salt and then keep adding more and more, eventually it won't dissolve. So how do I get rid of those crystals? And I need to get rid of basically the salt or the uric acid in your body to help cure your gout. But while that's happening, those crystals, those salt crystals and uric acid crystals in gout, those are going to be upsetting your immune system and causing these severe gout attacks and causing these severe inflammatory responses. So you need to both treat the flare, which we use steroids, and non-steroidal anti-inflammatories, and colchicine for, to treat the flare. But at the end of the day, to basically cure you of your gout, is we're going to need to get that salt or get that uric acid out of your body. And we use drugs called urate-lowering treatments to do that. Allopurinol and febuxostat being the most commonly prescribed versions of those drugs. And in very rare and severe cases, there's an infusion called pegloticase that we can use as well to rapidly lower your uric acid. And what that's going to do is just get rid of that uric acid, dissolve those uric acid deposits, dissolve those crystals to help prevent a gout attack in the future. As far as supplements are concerned, you may have read that tart cherry juice can help. And it may. There are certain studies that are trying to occur today to look into that. But usually the amount of tart cherry juice you'd really need to drink every day to have an effect, it would be more than you would actually want to drink. So who treats gout? Your primary care doctor and a rheumatologist. So what I hope to have accomplished today is to illustrate that arthritises are not all the same. They may all cause joint pain, but one of the most important distinctions that a rheumatologist or any doctor needs to make first when you're talking to a patient with joint pain is it inflammatory or non-inflammatory? Are you going to benefit from inflammatory medications or medications that focus more on treating that rusty hinge? A rheumatologist is not just looking at just your joint, but they're looking at your entire body. Are you having breathing issues? Are you having heart issues? And that as a patient, persistence is key. Persistence of treatment, adhering to your treatments, understanding your treatments, keeping up with your physical therapy is really key to being a success as far as improving your symptoms. But you should always discuss not just your joint pain, but the whole picture with your doctor and your rheumatologist so they can help figure out what's happening, because you need a diagnosis to match the correct treatment, because all these arthritises are treated differently. And that's it. Thank you. That's a great question. If you look at the studies, it's really dependent on different populations. And osteoarthritis was probably a lot more common when there were more manual laborers. So for instance, people who use jackhammers get shoulder arthritis. There was a lot more manual labor being done 100 years ago than today. But you also have to look at how do you define osteoarthritis? So clinically, we would say, well, it's a joint that hurts and then is non-inflammatory, and has an X-ray that looks a certain way. But other studies define it just as what you see under the X-ray. And as our last speaker said, you can see a lot of things on imaging that don't correlate to symptoms at all. So if we were to X-ray everybody in this room, every single joint, I would bet that we would probably find some changes on X-ray in almost everybody. Maybe a child wouldn't have it, but the older you get, almost everybody's going to have some changes to the joints over time. The question is, are they symptomatic? Are they a problem or not? So horrible side effects to some. I would argue a drug that has been around as long as methotrexate and is still the first line treatment and to treat rheumatoid arthritis, that's a damn good drug. And it is a damn good drug. About 2/3 to 3/4 of folks do get better on it. That's acknowledging that there are people where side effects or you're not able to tolerate it. You may have kidney disease that doesn't allow you to take it, or you may have, other, can cause nausea, can cause vomiting. And also it's not effective for everybody. So about 1/3 to 1/4 of patients aren't going to do better on methotrexate. So I will say it's great for those 2/3, but for that 1/3, no, it's not a good drug, which is why we have biologics, which is, so we have many different alternatives beyond methotrexate, but it absolutely should be first line treatment because of how effective it is and how well tolerated it is by most people, not everyone who takes it, but there are alternatives. Thank you.
Radio.